All right, well, welcome, everybody. This is Sean Greeley. I'm here joined by Dr. Lee Burton today, who's co-founder of FMS and Director of Athletic Training for Everett University. And Dr. Burton is presenting on understanding and implementing functional movement systems today. We've got a tremendous webinar prepared for you with great training on critical information for taking care of your athletes, taking care of your clients, and explaining exactly what the FMS system is for those of you who don't know it. Dr. Burton, I'm going to let you take it away and let me know when you're ready when you want to launch our first poll.
Okay. Thanks, Sean. I appreciate it. Thanks for setting us up. What I want to do today is just take a little bit of time. I do really appreciate all you guys giving up your afternoon on Tuesday to come in and hear me talk. I mean, obviously the FMS has become quite popular, especially here in the last few years. And what I want to do is give you kind of an overview of not just the movement screen itself, but our entire system. We've spent a lot of time and energy in developing, obviously the movement screen, but just kind of getting into more of where it was founded and where it came from. And then for those of you who are actually certified, kind of go into some of the latest research we've got coming out and kind of go into some of the other stuff we're starting to see based off of this philosophy. So that's the goal of this, is just kind of give everybody an overview for you guys that don't know much about it, let you understand a little bit more, as well as the people who have been certified, show you or kind of get into some more of the research and some of the stuff of where we're headed in the future. And yes, Sean, let me know if you can pop that up. Let me know kind of how many, if you got any information on who all certified. That'd be great.
Excellent. Yep, we're going to go ahead and launch our first poll. So go ahead and please join the poll. You'll see right up on your screen. Just go ahead and select one of the following. Let us know if you are currently FMS certified or if you're not. We're going to leave this open for just a few seconds here. Looks like we've got 70% voted. Again, go ahead and let us know. You just select one of those buttons on the screen, and we will close this out and continue. And we're just about there. I'll let this get to over 80% voted. We're at 78%. So again, go ahead, click into one of those options on the screen if you haven't done so, and we will close this out. Okay, perfect. We're going to close the poll here, and we will share the results. So you can see we're 50-50. We have half the room here is certified, half is not. That's tremendous. We've got great information for you guys, and Dr. Burton, I'll close the poll out and kick it back to your slides.
All right. Okay. Great. Thanks. All right. And so yeah, I think we're going to get some really good information from both groups. I mean, the people who haven't had a lot of experience with the FMS, and of course those who have been certified, whether it's through a workshop or a home study course. I mean, I want to introduce some new information and kind of get into the entire system, kind of show you the breakdown, because so many people. So many people have heard about the movement screen and its popularity over the last few years. And I think, as with anything, the more popular something gets, the more it becomes under the microscope, which for Gray and I and us here at FMS, that's fine. We really welcome that. The more we got a lot of research coming out. I think I think about 3 or 4 weeks ago at the American College of Sports Medicine, there were over 12 or 13 research poster presentations presented on the FMS, and actually Journal of Orthopedic and Sports Physical Therapy, actually on the front cover of that research referee journal, it's a reliability study on the FMS. So there's a lot of research coming out, a lot of more positive than negative, which is always good for us, obviously. But of course, we're always continuing to try to improve and enhance the information. And a lot of our research comes back from you all. Just getting the feedback, doing these workshops, getting this information, trying to continue to hone and really dial this information in. And the one thing that has been very impressive to me, even though I've been along for this ride for the last 15 years, is the one thing that hasn't changed over all these years is the actual functional movement screen itself. What I'm presenting today, what I'm going to share with you all, what some of you have been certified in, that scoring system, that screen, has not changed since it was developed in 1997. Many people don't realize that. Many people think that over the years we've changed it, we've altered it. We haven't. The only thing that we've ever changed is what to do with the information, and as well as how we present the information. We've learned a lot over the last few years. The movement screen has taught us quite a bit. It's taught us how to look at people different. It's taught us how to train people a little bit different. but the screen itself hasn't changed, and that to me has been pretty remarkable, because even when we started this journey in 1997, when the movement screen was actually developed, that was not necessarily the goal. Many people really don't understand or realize the goal in 1997 for me, Gray, and Kyle Keith and a couple of other colleagues was to come up with a system or a mechanism as part of the pre-participation physical for high school athletics. Many people don't realize that. That's what we really wanted to do. Is I was an athletic trainer working at a high school. Gray was a physical therapist. Kyle Keith was a physical therapist. We had an exercise physiologist involved. We had a lot of different, different disciplines represented. And, we were having all these high school kids coming in with problems. Gray literally walked in one day and said, you know what, we need to become a little bit more proactive. Let's come up with a screening mechanism. I've got some ideas. Let's throw them out there. Gray threw his ideas out on the table. And we worked through the process for about a year of how to score it, how to put it into place. And the idea was to turn this over to coaches and people in physical education in high school areas to do the screen as part of the pre-participation physical, to give the physicians and give the athletic trainers and physical therapists and people working with these high school kids more information on what needs to happen. Where do we need to focus our efforts? And from there, it's obviously just taken off. It's become a lot, somewhat of a, I'll use the word standardized very loosely, somewhat of a standard test for many people, which for us has been very humbling experience. But if you go back to where the roots of this came from, it's pretty simple. We were really trying to come up with something to be proactive, trying to, avoid injuries or decrease the risk for injury for high school athletics, and come up with a very simple plan. The foundation and fundamentals behind the functional movement screen have been around for many years. It's looking at basic fundamental movement mechanics. We just put it into a package and made it simple. And that's what we wanted to do. And if you think about what our primary goals are for any group, if everyone listening today, I'm sure, is an exercise professional that prescribes exercise some way, shape, or form. And if you're an exercise professional, your major goal has to be to reduce injuries. The first rule of any exercise professional should be, first, do no harm. Don't screw them up. We've got these individuals, whether you're a high-level athlete or whether you're just a weekend warrior or whether you're, a person sitting at the desk all day that wants to get in a little bit better shape. First, don't do anything that's going to put them at higher risk. And I think in doing that, we need to first understand, just like anything, if we're trying to reduce your risk of something, we need to understand what the risk factors are. If you consider what risk factors are for something as simple, I should say simple, but something, like a heart attack or cardiovascular disease, what are those risk factors? And most of us could spout this off really quick. What are some, a person walks in off the street, the first thing you want to do is, okay, let's make sure this person is ready to exercise. Let's first make sure this person's not going to have a heart attack on the treadmill. And we can start categorizing and separating people out for cardiovascular disease with some basic questioning. What's your family history like? What's your diet? Let me take your blood pressure. Those are some simple things we can do that relate to risk. And we have to do the same thing with injuries. And injuries, injury risk factors have been researched over and over for many, many years. And it's been it is and will always be very difficult to start and talk about injury risk factors. Very multifactorial, a lot of things come into play. But we need to start looking at what are some of the most consistent risk factors for injuries. And that's where we need to start, because there's so many different factors that go into this. How active are you? Are you overweight? Do you, what is your daily activities like? All these things we have to consider, but let's try to be consistent in what we're looking at. And more recently, research is really indicating that the most consistent risk factor by far and away is someone who has had an injury in the past. So if you've had a previous injury, your risk for injury is highly elevated. Now, that's somewhat of a problem, because how many of us out there that are listening have had an injury? And I'm thinking if you were active at some point in your life, you probably had some sort of injury. Whether you've had back pain, whether you've had knee pain, whether you sprained your ankle your sophomore year in high school. And then if we take that and think about your clients, well, you're very few people that are active or have been active have gone through life without any injuries. So that statistic in itself is good to know. It's very difficult to really be able to apply that information. So what we have to do is take it to the next step and think about what has that injury done to the body. And now we get to the next layer of consistent risk factors for injuries, and that is asymmetries and motor control, proprioceptive problems, balance issues. So if a person who's had an injury in the past, more than likely that injury has left the person with a disconnect between what the brain is telling the muscles and body to do and what the muscles and bodies can actually do. So whether they've created an asymmetry in the body, or whether that injury has actually created a motor control or compensation in the body, that individual, based off the research, has created this motor control problem, which now, through research, tells us that they're probably at higher risk for injury. So now we're starting to get somewhere and starting to dial this injury risk down a little bit, and not just looking at people who have previous injury. What does that previous injury cause? And now we can take that information and take it a step further. Because we got to determine asymmetries, we got to look and see what is that previous injury cause, and even if the person hasn't had a previous injury and they've never had any problems, do they still have a motor control problem? Does something in their daily activities, or do they have an issue that they have some balance or proprioceptive issues? That's what we're looking for. And then the next one is proper progression. I think this plays a huge role in looking at reduction of injuries. Our job as exercise professionals is to push a person as hard as we can push them without pushing them too far. And that's a very fine line. I think what we have to do is we have to know where that area is. Sometimes we may go over the cliff. Hopefully we don't go over the cliff too often, but we all know that if we're doing our job as exercise professionals, we've got that person that they're doing great. We're pushing them. Hey, we push them a little bit too far. They did a little too much. They get a little bit of tendonitis. We need to back off a little bit. That person that's out there that's running 10 miles a day, they come in with shin splints. Well, you shouldn't be running 10 miles a day. We have to back off. So that progression definitely can create problems. So even though the person may have great balance and have great proprioception, motor control system is great, they move great, our actual exercise protocol can create some of these issues. And I think that's what we have to be aware of. So our progression is definitely something we have to consider. And then if we start talking about post-injury and return to play, or not even just play, but just participation, going back to what the major risk factor is, previous injuries. Well, if that person has gone through rehabilitation, they've seen a therapist, they've seen a chiropractor, they've done what they needed to do, they've seen a physician, but the risk factor still there, the previous injury is the biggest thing, then why is that? Because maybe they weren't rehabbed completely, maybe they didn't seek out the right person, whatever it is, it doesn't matter, that we have to address that. And I think that's where we have created this system, that we have both a screening mechanism and an evaluation mechanism that we both utilize to make sure the person is make sure that we're not just working on that one area. We want to make sure we're working on the entire system. We got to make sure we're working on the individual and not an ankle joint, not a hip joint. We're making sure that we're taking care of the entire individual, making sure the movement patterns are dialed in, making sure that ankle sprain that they had, if they're coming in and getting rehab, is not altered their motor control system when they leave. And now too often that to me is what leads to some of these risk factors is those motor control problems. So we got these compensations, we get these daily activities, poor training, previous injuries, creating this whole, this situation where everything is working off of each other, and we're basically creating movement pattern dysfunctions. And these movement pattern dysfunctions are what we have to get away from. We have to look and think, okay, we can't just say the person's moving great, let's push them. We may push them too far, which is poor training. Previous injuries is going to throw a monkey wrench in the whole thing. But then we also have to address, which most of us, even us, people, me included, what do we do most of the day? Most of our clients, most of us. I mean, I sit at the computer quite a bit of the day, typing and answering emails and doing certain things. And I'm sure a lot of you all listen to do the same things. But those are daily activities that we have to address. If my typical job forces me to turn a certain way or forces me to do certain things, those types of overuse situations create compensations, create asymmetries that may be a problem. If I'm sitting all day at a desk and I develop poor posture, giving you a few corrective exercises may not address that issue. So we have to look at daily activities, nutritional habits, things like this that may also create or lead to some problems. So we have to think about all these things and how these things may lead us to movement pattern issues, because it does go back to movement pattern problems, motor control problems. Because again, going back, what's the first thing? What do we have to consider as far as a risk factor? Previous injuries are number one, but we can't control that. That's already happened. Where does that lead us? Motor control, balance, and let's make sure we got the foundation. And we have to understand what's creating some of these problems, what's creating the poor foundation, so we can then address that, and not just through movement. Because if we're looking at just movement, and we fix the movement pattern, but yet they're still doing certain things on their own, we've got a person we've dialed in movement pattern-wise, and we've got them moving great, but yet they're still running 20 miles a day, coming in complaining about shin splints. It's not the movement pattern that's causing the shin splints. It's that overtraining, that poor training mechanism that's creating that. So we have to be aware of all those things and how they play off of each other. So if we want to start moving, we got to move right. We got to create a logical approach, and that's where this whole movement screen really came about. And when we started cultivating this, is we had to look at the entire situation. And if we're going to be consistent, and we're going to try to be consistent across the board, not just with my individuals, but if I'm out here and I look at our university setting that I'm affiliated with, and I look at Gray and the clinic that he oversees, is that I want everybody there being on the same page. I want the communication to be very consistent. When I screen a person, and this person got a very, very poor movement screen, I want the strength coach to know what limitations this person has in the weight room. And I want to know vice versa, hey, this person can do this, but I've got to watch this. And this logical approach of being very consistent allows us to make sure it creates great communication, it creates great consistency, but it really helps us to avoid missing certain things. We screen our freshmen coming in August every year. Well, by doing that, we got it down to a science where it's very consistent. Everybody's on the same page. We know what to expect. And that really helps us try to avoid certain things that can fall through the cracks. So that logical approach of screening them out, making sure, just like going back to our risk factors, let's put them in categories first. Who are the people that have the biggest problems? Then let's go and test those people out. Let's figure out, okay, they've got some significant limitations in this area. Let's figure out what's creating the limitation. And once we do that, let's assess the situation and figure out what's the best category to put them in. Do they need to be training at a high level? Do they need to be doing some corrective work? Or do they need to see a physician? And for me, that's many times the way I approach it, because the screen is not about corrective exercise. The movement screen in itself is about figuring out, what does this person need? Too often your individual is going to come in and tell you what they want. That's easy. Everybody's going to tell you what they want to do, and many times what they want to do is what they're good at. It's our job as professionals to tell you what you need to do. And many times what you need to do is going to be out of your comfort zone. And that's what this approach, and that's what trying to create this baseline is all about. Try to correctly identify what is the dysfunction. And when I say dysfunction, it may not always be about what their movement pattern is. A movement pattern could be a result of having a back pain or shoulder pain. Their movement screen, their movement problem may create the pain, but I don't know. So my first thing is, what is the biggest dysfunction I've got to deal with? Is it pain? Is it movement? Or you know what? They look good in both of those. They're ready to go train. So the idea behind this whole thing is, let's make sure we got the basics down, and from there, let's go train. But if we don't have the basics down, you're going to get something entirely different. And I think that's what we try to create this entire system. And that's what we've done by breaking these two things down. We have, and when we start talking system, these are the two things we're talking about. We're talking about both the movement screen and the functional movement assessment. Because the movement screen is designed to be done on active individuals who are coming in ready to work out. They don't have any problems, or they don't know they have problems. They're coming to you saying, hey, I'm ready to go. My freshmen coming in August ready to start playing football or soccer or whatever sport they're playing, they're coming in saying, I'm ready to go. My job then is to screen them so I can then check them off and make sure they're ready to go, make sure they don't have any major problems. And if they've got major problems, the line in the sand for us is the SFMA. Because basically, once a person has come in or once the screen has uncovered pain, or once the person has come in saying they have pain and they need to be assessed, that's where our evaluation takes place. That's the difference between the two. The movement screen has never been designed as an evaluation. It's always been designed as a movement screen. Let's screen them out. Let's put them in a category. Where does this person need to be? Do I need to refer them to a physician? Can I train them at a high level? or can I give them some basic correctives that will get them to where they need to be? And the SFMA basically is there as the actual assessment to determine, okay, the movement screen was terrible, you had shoulder pain. Well, let's figure out why you got shoulder pain. Let's figure out what area, what movement is the most dysfunctional. And based off that most dysfunctional area, let's figure out what is causing that dysfunction. And then prescribe some therapeutic techniques based upon that. So we're going to treat the pain, we're going to evaluate it, but we're going to evaluate it to determine the biggest dysfunction. And we're going to go from there. So the SFMA and FMS are two different systems. Now, if you see them both, and our recommendation is always, if you're a medical professional, that's what the SFMA is for. But you may use them both, and they're very similar. The FMS actually takes a little bit longer to do. The SFMA, the top 7 tests only take a couple minutes. From there, you're going to break it down and go into a little bit more of an orthopedic type evaluation. But that's the line of the sand. I think that has created some confusion for certain people that have looked at the movement screen and said that it's not sensitive enough. It doesn't tell you everything. Well, it's not designed to do that. It's designed to be the intake. It's designed to be the blood pressure for movement. And if you take someone's blood pressure, it doesn't tell you everything. It just tells you there's a problem. And that's the movement screen. It basically says, is there a major problem, or is this person ready to go? And if they're not, give them some corrections or refer them to the right person. The SFMA is there to help you actually diagnose and to figure out where's the biggest dysfunction. And I think that's why I really want to get into and talk about those two during this short webinar. So now let's kind of get into actually some of the typical situations and how you want to use this system and how the system can benefit you. Basically, right now we want to identify where's the biggest dysfunction, where's the problem. So a person comes in the door, let's figure out what do they have. And for most of us, most people in general, looking at this situation right here, this takes care of a lot of people. Right now, if you were to ask me what are some of the biggest issues with people, I'm going to say they got tight hips, and most of them have tight upper backs and T-spines, thereby leaving a very sloppy and dysfunctional core. Now, I'm not saying which one is coming first, but I'm saying this is a typical situation because it's very difficult to say which one came first. However, what we have to do is identify this is the problem and then put it into our system to make sure that we correct the problem. So we can take someone who's got tight hips and ultimately loosen up their hips. But if we loosen up their hips, we've got to make sure we create stabilization somewhere else. So the hips are stiff, but the hips are stiff, the low back compensates by basically becoming unstable. So if we create some mobility in the hips, we need to make sure we create some stability in the core. And we always go back to our mantra, which is always mobility before stabilization, mobility before stabilization. Doesn't mean stability is not important, but in order for the proprioceptive system to work, in order for our brain to really capture it and get the motor control system back to where it needs to be, we've got to create mobility around the body. Now, not everybody needs to be focusing in on mobility. There are certain people out there that have tremendous amount of mobility. We got to look to stabilize them. But here's just a typical situation that we may be faced with. So what we're trying to do is get them more like this. Get the hips mobile, stabilize the core, get the T-spine mobile. The ankle's another situation. The ankle many times is very stiff. But we got to create some mobility there because what's happening further up the kinetic chain in the low back or the knee, as an example, those areas may be compensating for that lack of mobility. And that's what we need to start thinking about. And vice versa. You may have some situation where you have a lot of instability, area of the body is trying to create some stabilization for that. What we're trying to do is not just focus in on that one area of the body, but focusing on the entire pattern. Because I know that if one area of the body's out, it's sending a dysfunctional signal somewhere else and creating an inefficiency. So what we're trying to do is be a lot more efficient in how we're approaching these things. It's not just about prescribing an exercise. It's about making sure that the exercise you're prescribing is getting the result you want. So if I'm giving you basically hip mobility activities, but I'm not making sure I'm putting that into practice and making sure that hip mobility is being worked around a good, stable base, then I may be missing it. How many of us have gone through and stretched out someone's hamstring and stretched them out? That's a common situation. People come in and complain about hamstring tightness all the time. So our initial reaction is to say, okay, let me stretch the hamstrings out. And lo and behold, 3 months later, you're still stretching the hamstrings. Well, the hamstring stretch is not the bad exercise. It's what's being put around it. So you're increasing the mobility in and around maybe the hamstring or the hips at that particular time, but you're not reestablishing the movement pattern. And that's what many times we miss. Most of us do a really good job of doing foam roll, movement prep, getting the person moving initially. But as we go through our program, the person falls back into that poor motor program. They fall back into that poor proprioceptive system that they're accustomed to, and lo and behold, the next day they show up just like they were before. And we do a good job of getting them loosened up. We need to take the next step. Let's get them loosened up. Let's add some good movement pattern type activities on top of it, so then we can start taking more steps. So we don't have to continue to stretch out the hamstrings every time they walk in the door, so they're not continuing to complain about hamstring tightness. That's what we're trying to figure out. That's what we're trying to do. And by showing you this pyramid, it's basically a visual representation of putting people in these categories. This pyramid has become pretty popular for me just because it's a great way for me to create a visualization and how to explain this type of model to many of my athletes. Many times I'll present to my athletes at the university that I'm at, and this is what I'll show them. This first thing I'll show them is, listen, it's not that we are telling you not to lift weights, not to focus on how much you can lift or how fast you can run. That's always got to be part of what we need to do. That's performance. That's that physical capacity or performance-related area we want to improve. However, what we've got to do first is make sure you've got the foundation to lay good performance, good strength, good power. If I've got a car and I take a little bit of air out of that right front tire, I can still drive the car. But the faster I drive it, the more likely I'm going to be to either blow the tire out or hit the wall. So what I've got to do is, first and foremost, make sure the brakes work, make sure the alignment's there, make sure I got all the air and all the tires and it's the right pressure. Because if I don't, I can still do certain things. And here's the other thing. Many people, especially athletes, are very good at hiding those minor problems. And that's what we got to do. You know, just having a little bit of air out of the front tire may not be a big deal right now, especially for an 18-year-old kid. But the more power they put in that engine, the more stuff they do, the more likely they are to have a problem later on. And I think first and foremost, let's just check under the hood. Let's check everything out. And then let's look at laying some stuff on top of it. So just like I said earlier, when I first kicked this thing off, we're just simply trying to put them in categories. And this is a good way to just represent those categories, is making sure, hey, movement's the foundation. Do we need to work on that or not? And if we don't, great. Let's just make sure that we always go back and check it so movement patterns aren't becoming a problem based off the performance we're laying on top of it. Because I could have a person who gets a 2 on the squat, as an example. For me, I could probably train the squat. I could do some front squats as an example, watch the technique and make sure they do it. But however, that person's a 2. So if I continue to load that squat up and I let that person go for a few months and I don't check their technique, that person could easily slip back into a 1 category. So I need to make sure I get into that 2, and I got to make sure I at least maintain that 2. Again, if you're not familiar with the movement screen, we have a scoring system 0, 1, 2, 3. 2 is that middle area that we're trying to at least get to. That's kind of the minimum. Okay, 3 is great. Let's at least get the minimum. And for us, that's kind of the cutoff for us. We got to get to that point. But if I'm going to lay some strength on top of that minimum standard, I got to make sure I go back and don't just let them go. They're still in an area that I've got to kind of watch them. So this pyramid and this visual is for us just an easy way to kind of categorize people, figure out where we're going to put them, and just let people know that it's you still got to have strength, you still got to have power. We've just got to make sure you're ready to do it. So when we got back to the basics and looked at how we wanted to form this movement screen, going all the way back to 1997, and we looked at these fundamental patterns, looking at some of the people that have influenced us, Vladimir Yanda, Gary Gray, all these people that talked about function and talked about initially how we first learned to move, you have to go back and look at growth and development. How did we go from being an infant laying on your back, not able to do anything, not even able to hold your head up, to walking in a matter of 12 to 15 months on average? That's a ton of proprioceptive, a lot of feedback, a lot of motor control. It's not strength. And it doesn't take a lot of practice, to be quite honest. And when I say practice, the better word will be a lot of cueing. Let me just change the word from practice to cueing. It doesn't take any cueing. It just takes a lot of falling down, to be quite honest. So how does a baby do this? They just take up all this information. Their brains take in all this information. They problem solve. They motor program. They learn to do this stuff, and then lo and behold, they're walking, they're running, they're doing all this stuff, and they follow a very specific maturation and maturation and growth and development process. They learn to stabilize their heads. They learn to stabilize their spines. They have tremendous amount of mobility. Going back to this whole mobility first thing, look at a baby. The baby's got great mobility. Proprioceptively, they're wide open. They're taking in all this information, all the proprioceptors from their hands and their feet, feeding the brain all this information, and they learn to stabilize. So they got this great mobility. They learn to stabilize it around their spine, their hips. They start crawling, and then they start half kneeling, and then they're off and running and walking. And that's a tremendous amount of information that's taken up. Well, we're simply trying to go back and look at this with a movement screen. We're simply trying to say, okay, let's look at the basics, and let's make sure you got the basics down. And that's where we came back to. So we started looking at the movement screen, and we started not just looking at the different movements, we also wanted to start categorizing and rating and ranking the different movements. Let's look at our algorithm. Let's look and see, okay, where do we need to prioritize things? What do we need to make sure that a person can do first before we move them on to something else? So our movement screen is very much just a blueprint of fundamental movements. And when we start talking about what to do with the information, let's look at these fundamental movements and let's figure out which one takes priority. And we went back and looked at growth and development when we started doing that. So if you look at the movement screen, and here it is, you look at the top three: squatting, stepping, and lunging, reaching, leg raising, push-up, and then we have a rotary stability. These are basic fundamental movement mechanics. Now, how we make you do them in this test is very challenging. It pushes you to your limits, but that, in essence, is what a test is. A test is basically trying to determine what do we need to work on. So having you squat with your hands above your head is not a normal squatting pattern. You want to keep your hands in front of you, turn your feet out so your heels a little bit more, or your hips are a little bit more opened up. Having you lunge with one foot directly in front of the other, how we do the lunge test, is not a normal lunging mechanic. It's not a typical movement pattern, but we make you do it in the test, simply trying to make the test reliable, and more importantly for us at the time when we developed this, trying to make the test difficult. We need to capture the compensations. We need to see the mistakes, and we need to see the limitations. So by placing you in these very difficult positions, these compensations, these limitations that we're looking for become easier to see and identify. Remember I said what I said earlier. We're not trying to see if you're perfect. We're trying to see if you can just make the minimum. And that's why we have you in these very difficult positions. The top three tests are functional: squatting, standing on one foot, and lunging. That's how we move every day. You're either in a symmetrical base, single leg stance base, which is your hurdle step, or an one foot in front of the other, or asymmetrical or split stance base. So we're in those 3 foot positions throughout the day, and that's how we function. And most people assume the top 3 things, those are the most important. They are if you're talking about function. But we're talking about dysfunction, and we're talking about how to make sure you can function. And the bottom 4, and this is what we learned, this is what we started seeing the more we looked at this model. Over the years, what we started seeing is reaching, leg raising, the push-up, and rotary stability lay the foundation for you to be able to squat, step, and lunge. So as an example, consider this. If you've got a very poor squat, and you've got a very poor shoulder mobility test or your reaching test, you're very limited in how you do that, then why did you fail the squat? More times than not, you may have failed that squat because of how your upper back is involved, how your reaching pattern is involved, or looking at the leg raise. You've got a very poor lunge pattern, a very poor hurdle step pattern, and when you lay on your back and do your lunge, you can't raise your foot only up 6 inches off the ground. Well, there's your mobility restriction. There's your problem. And if we correct that problem, how does that affect how you function? So that's what we started looking into. The bottom 4 things are what we looked into more than the top 3. Not that the top 3 are less important, but as far as our algorithm, as far as what we do with the results, we started thinking that, you know what, the reaching, the leg raise, those are mobility type activities. Let's make sure those are clean. The push-up, the rotary stability, those are motor control. Those are more stabilization activities. Let's get the mobility, make sure we can stabilize it, and then can we actually put it into function? So we look at this is a very good blueprint of how you move. One test is not more important than the other. We want to make sure we look at all 7, because all 7 is going to give us our baseline. When we start, when I say not more important, when you start looking at the algorithm, we're certainly going to rate and rank certain movements differently. But we need to see a good blueprint of all, because if I fix one, I want to see how does that one that I just corrected fix, or does it alter another pattern? And what we started to see, and is the case, is yes, it does. So by fixing the leg raise, we may actually have a positive effect on another pattern. So scoring the FMS. Let me just go through this really quick. For some of you guys that have seen this before, it should be a review. But what we're looking at right here is simply, we looked at a 3, which is the pattern is performed perfectly. 0 is there's pain. A 1 is they can't do it at all. And then a 2 is they can perform the pattern with compensation or imperfection. So right now, really quick, 0, it hurts. Anything hurts, it's a 0. 3, they do it perfect. 1 is they can't do it at all. So that leaves a lot of 2s. And 2 for us is what I would consider average or normals. Let's get to symmetrical 2s. A 3, hey, that's perfect. And when we're designing any test, we're trying to create a bell curve. And this scoring system allows us to get to that bell curve. A 2 is okay. 3 is perfect. Not a lot of 3s out there. A 1 is not good. Not a lot of 1s out there. A 0 is the worst thing, because then you're already in pain. You've got some significant problems. So we're trying to make this very simple. And many times the debate is whether a person's a 2 or a 3. And if you think about it, if you're that close to a 3, and if you're looking at the person and you're thinking, well, they're pretty close to a 3, let me just give it to them, that's not a real problem. When I say that's not a real problem, you shouldn't give them the 3, but that pattern is not the problem. If they're that close, you may debate it all day, but don't debate it. Just give them a lower score. And our rules always tell you, when in doubt, score it low. And when I'm talking about the debate between testers is whether the person is a 2 or a 3. Very seldom, we all typically agree on whether a person is a 1 or a 2. So when you start looking at the scoring system, and you're trying to ask me as a person who's been doing this for many years, whether this person's a 2 or a 3, honestly, give them the lower score. But that's not going to be the thing you're being worried about, because they're already pretty good at it. So you're not really worried about that area of the score. So the first test is the deep squat, and these are in no particular order. You could do other tests first, depending on the situation you're in. We have them laid out this way simply to do the standing test first, and then go into the tests that are on the ground or on the floor. So the deep squat doesn't necessarily need to be first. If you're screening someone one-on-one, I recommend doing it this way. But if you've got a large group, you could certainly alter it. The one thing that we have had people ask us about is do I want certain populations doing these movements? Well, if you think about how our scoring system is laid out, if they don't even do the move, they just sit here and tell you, hey, I can't squat, or I don't want to squat, then they're going to get a 1. I mean, the only thing that's going to give them a 0 is if it causes pain. And if a person grabs the stick and goes down 2 inches, doesn't hardly try to do it, they're still getting a 1. So I don't really have a problem with any person doing these tests. You're just telling them to go down as far as you feel like you can go, and let me know if anything hurts. So by giving them those simple rules, they don't need to go down very far. And if they don't, they may get a 1. So it's not, you're not trying to see if they can, like in the video, take their butt all the way to their feet. How far can they go? And what we're doing is we're scoring this based off of the rules we've set out. And the rules simply state that the stick needs to be over the foot, the torso and tibia need to be parallel, and they don't need to have any valgus collapse in the knee. So basically the knee needs to be over the foot. And then we position them with feet shoulder width apart and stick right above the head. Now, for our purposes today, I won't go into all the little details, but you get the idea. We're looking to see if a person can do a good overhead squat. And again, we're not talking about squatting with weight. This is a squat pattern, okay? So a little bit of rounded spine right there is not a big issue as low as he is in this area, okay? He's got no weight above his head. He's just doing a body weight squat. Now, again, these are very strict positions we put them in. But again, I've addressed that earlier to making sure we get the right bell curve or the right scores that we're looking for to see those compensations. The next test is going to be a hurdle step. Now, the hurdle step is done, again, we're looking at single leg stance. So again, what we do is we have a person standing directly in front of our hurdle. We line the string up at the tibial tuberosity, and we're trying to determine, can they step over the string and keeping a very stable torso. So basically the head, the trunk doesn't move. They keep everything nice and stable. They don't flex the spine. They don't internally, externally rotate the hip. They don't collapse their knee. The foot comes straight up. They come over. They touch their knee. They go back to the start position. And again, this is extreme. And we're not expecting a lot of people to be able to do this perfectly, but that's fine. The more important question is, can they do it? And even if they have to compensate to do it, they're going to get a 2. If they can't clear the string at all, they're going to get a 1. So if they can't do it at all, they can't balance on one foot at all, they're going to get a 1. But if they can balance a little bit and do the move, they're going to get a 2. And a 3 is perfect. Remember, a 0 is always going to be with pain. So as you can see, a 2 is going to be really what we're trying to get. We can maybe see some improvements. A 3 is great. That's fine. But we don't want to see 1s. We're looking at the bottom part of this is what we're trying to avoid. Let's make sure we don't have any 1s here. The next test is going to be a lunge. So we have the stick touching the head, the T-spine, and the sacrum. And then we simply have them take their knee, take it below or back behind the front heel, keeping everything touching, or keeping the stick touching the head, the T-spine, and the sacrum. So basically keeping a very upright and vertical torso, making the motion come from the hips, looking at ankle mobility, hip mobility, knee mobility. A lot of different things are going on right here with these movements. It's not just looking at one joint of the body. Again, we're looking at patterns. And one joint could disrupt the entire pattern. So what we have to do is make sure we correct the pattern. We correct the pattern, we corrected the dysfunction. And that's what we want to do. But first and foremost, we have to identify the dysfunction. So, again, for a 3, they take their knee straight down behind the front foot. More of a split squat than a lunge because you're not stepping. We start the movement by simply having them already in this position just to avoid any of the problems that may come about by trying to step. And then can they lunge down? And by having you in this inline position, we are really winding up the body, really forcing rotation and trying to determine, can you avoid that rotation? So a 2 is if they do it, but not perfect. 1, they can't do it all. And of course, 0 is pain. The next test is shoulder mobility. So we look at shoulder mobility and we try to determine how close they can get their fist. If they can get them within 1 hand length, it's a 3. If it's a hand and a half, it's a 2. If it's greater than a hand and a half, it's a 1. With this test, we're not just testing the glenohumeral joint. We're looking at the entire upper back and shoulder complex. So we're looking at a lot of different things here, not just the shoulder. The same can be said for the leg raise. So with the leg raise, we have the person lie down, actively bring their hip up into flexion with both knees extended, both hips neutral. And when I say neutral, that neutral is no internal or external rotation. My points of reference are going to be the middle of the knee, the ASIS, or the bony part of your pelvis, and I'm going to drop that stick halfway between that. So I'm going to be looking at the mid-thigh. And if their malleolus ankle can pass that mid-thigh area with both hips remaining where they need to be, they're going to get a 3. If the malleolus goes between the knee and the stick or mid-thigh, that's going to be a 2. And if it can't go past the knee, that's a 1. So again, keeping along our scoring criteria, 3 is great, 2 is okay, 1 is very poor. And then we're looking at a person's ability to avoid extension. So here we're looking to see when Paul does this push-up in this position, can he avoid hyperextension in his low back? So you're pressing with your upper body, but you don't want to have any extension here. And our scoring is basically hands above the head, do a push-up without any lagging in the lumbar spine. If you can't do it with your hands above your head, you lower the hands down to chin. See if you can do it there. If you can't, you're going to get a 1. Females, we change it up slightly by starting with a hand position slightly lower at chin level, and then if you can't do it there, you lower it down to shoulder level. And then our final test is going to be rotary stability, and this is one that has, over the years, has been very controversial for whatever reason, mainly because many people can't do it. But if you go back and look at our scoring criteria, the scores here are very similar to scores in other tests. We're simply pushing you to the extreme with this same side flexion and extension pattern in quadruped. That's going to be 4-3. And if you can do that same side, you're going to see Paul do it here in a second. Same side flexion and extension, that's going to give you a 3, keeping a nice stable spine as you see here in the video. And then you do the opposite side. That's extreme. We all know that's a very difficult, high neurological type activity. However, for a 2, we're looking at more of the traditional flexion and extension of the opposite side. So if you can't do a 3, that's fine. But can you do the right arm and left knee? Take them out, the flexion, come back into extension. That's what we're looking for. So we look at a quadruped pattern, the same. Can you do the alternate arm and leg for a 2? And if you can't, you're going to get a 1. So what we're left with is we're left with this. We're left with a scoring system, the scoring page. It looks something like this. We score the right, we score the left. We get a total score, which is what we want. And from here, we're just trying to determine what are some areas that we need to work on. What are some things we need to consider? And it's going to tell us 2 things from this scoring system. What can the person do? And what should the person avoid? And many times the person may not need to avoid much of anything. A person that has a 15 with very few asymmetries and scores look mostly 2s and a few 3s, this person may not need to focus a lot of their time on correction. They may be okay to move into other activities. But too often, the focus is, let me go back to this slide. The focus is over here on the final scores and this number 15. And quite honestly, that's not where you should be looking at. This number is good to talk about generally speaking, and some of our research looks at this. But when we start talking about what to do and get a better blueprint for this person, here's what we need to look at, the raw score. What do the individual scores look like? A person who's a hurdle step, who's a 2-3, an inline lunge, a 2-2, shoulder mobility is a 3-2, and then the leg raise is a 1-2. Look at these individual scores. That's going to give you a better picture. And a lot of times, looking at different groups, many times this has become the breakdown for most people. And when I say most people, most different groups, whether you're Navy SEALs, whether you're NFL players, or whether you're just general population. Typically, what we're seeing is most people fall into 0, 1s, below 14, or have 2, 3 asymmetries. And here's the problem. This is our low-hanging fruit right here. Let's address these 0s and 1s of people who have below a 14 score. That's what we need to be focused on. The people who are 3s and 2s, they get a good workout. They're in good shape. Don't let them get worse. They're okay. The people who are 2s and 3s, let's make sure we keep an eye on them. But this is our problem over here. That's our high blood pressure group. That's what we need to focus on. And after you work with this group for a while, simply try to get something that looks more like this. And these are good representations of people that are using our system. This is what they're trying to get to. Take them from something that looks like this, a lot of 0s and 1s, a lot of major issues. And after a few months, let's get them moving a little bit better. And let's simply try to make that red part of this pie smaller. And that's what we're trying to do. So what we're trying to do in summary here is create an idea or standard operating procedure, that's the SOP, and figure out what does the person need to be doing. Do we need to focus our efforts on conditioning or correction? Not everybody needs corrective exercise. And I think Gray and I have really been pigeonholed in this corrective exercise specialist, not because we want to, but quite honestly because we are identifying the dysfunctions. And we're telling you make sure you correct before you condition. That's not what we want to do. We want to condition people. We want to improve their physical performance or physical capacity. But if they're not ready to do it, we don't need to be doing it. So we got to figure out where do they need to focus. And then improve the communication within our groups, within not just ourselves, but our coaches, our parents, the people we're working with, and then avoid the re-injury. Retesting, maintenance, make sure if they've had an injury in the past, realize that injury in the past is creating some dysfunctions, motor control problems that we need to address. And just kind of finishing up here, organizations that have used our system successfully, we've done a lot of work with the NFL, a lot of work with Major League Baseball, pretty much all the professional sports, certain teams have used our system with some significant benefits. A lot of stuff with the military at this point. We're getting into some occupational stuff, and I'm going to kind of give you some statistics here in a second. I had a question actually. Melissa, who handles a lot of our emails, asked me this question about this bullet point right here, military special forces. This is not a research study that was done. This is some data that we collected from one of the special forces unit. Before this, one of the strength coaches came on board. Their injuries were training related, strength condition related, with 37% of their injuries. He implemented the FMS, implemented the system that I went in and helped him screen his guys and started giving some corrections, and it went down from 37% to 10%. So quite honestly, the FMS was a piece of the puzzle. It's not the whole thing. The FMS is a tool that will help direct what you're doing. Ultimately, it's up to you to figure out how that tool is best utilized. We're just simply giving you, or what we're hoping to do is give you the tool. And then, of course, some of the areas we're trying to focus more on is occupational areas. Orange County Fire Department, Midwest Power and Light saw significantly reduction in workers' comp costs when they started using the movement screen. And here, I've got some other studies that I can go through. We've got some other research that's on our website. If you go to our website, functionalmovement.com, we've got a really good reference list that's continuing to grow. I don't want to get into all the research that's out there. I can certainly take questions on that. But we've got a lot of research out there right now, a lot more coming up. One of the ones that's actually coming out, and this is not research, but it is going to be published in a journal, the journal Work on Occupational Injuries, looked at a fire academy, Orange County Fire Authority, which has 113 recruits over 4 academies. They simply followed these recruits after screening them. And what they realized is that if you score 13 and below, you incurred 80% of the workers' comp costs. So this is some stuff we're really starting to get into and look into more with the military, fire departments, different type of occupational groups, because this is significant. Basically we followed the information. We didn't do anything with it. Looking at this data, these people who are scoring low are creating a lot of the problems. And here's what was also interesting, talking to Mike Contreras, who gave me this data and who's worked with us quite a few years. He said, the interesting thing is, the thing to consider, is the people who score above a 14 or above a 13 get hurt, but they come back to work quicker. And that's the interesting thing to take away from this. And, if you look into this, the guys, it's not, some of this information, some of the results, injury statistics and things like that. We're not saying that people above 14 are not getting hurt or not going to be as prone to injury. The injury risk is still there based off other factors. However, some of these costs incur because they may not get back to work as quick. So these things are some things you got to consider and look at some of the data. And here's another just representation. 826,000 was from people that scored 13 and below. 208,000 was from people that score 14 or above. So some significant cost associated with this. We've seen this in different groups, not just with firefighters. We saw the same thing with Midwest Power and Light, which is Bill Friedig out there as a strength coach who basically is overseeing 1,200 public utility employees. And he's actually going in, he screens his guys, he gives them a foam roll, gives them their corrective work. They do it every day before they get in the truck, and their workers' comp costs and their injuries related to that have decreased dramatically. So, we definitely are seeing some things that are a little bit different. So those are some things that are coming out. We got some other, like I said, other research. I'd be more than happy to talk about that. We got a very special event. That's one thing that I want to talk about here as we wind things down, take some questions. Gray and I did this last year, and we had a great turnout for it, and we decided we wanted to continue this. Down at Duke University with Dr. Rob Butler, we do a really, really cool event over 4 days. We teach both the FMS and the SFMA. We bring in some other instructors. We really treat it more as a summit than just simply an FMS level 1 and level 2. It's going to be 4 full days. A typical FMS level 1 and level 2, they're 2 days, but we really make them over a day and a half, a day and 3/4. Well, these are going to be 2 full days. Gray and I are going to be there the whole time teaching, really exchange some ideas. So that's going to be July 25th through the 28th in Durham, North Carolina. If you call in, you get a 10% discount. So if you call in the number, If you think you can make that trip work, I definitely would recommend it, because we're going to have not just Gray and myself, we're going to have some other both SFMA instructors as well as FMS instructors there, kind of hanging out, exchanging some ideas, doing some good stuff. So I highly recommend, if you're going to try to, if any of this information has intrigued you, we just scratched the surface, to be quite honest. I definitely think these two, trying to make these dates would work. We certainly have other dates that are out there. We're teaching these things all across the country. We have a home study course that we do, but certainly this is pretty special, because you're going to have a lot of these guys there that help us out with these things. Just kind of give you a rundown of the level 1 course. We get a lot of questions about that and the difference between this and level 2. The FMS level 1 is really going through a lot more detail of what I just did, going into a lot of the philosophy behind it, how to do the FMS, and also how to interpret the results, and how to relate those results to corrective exercise, and how to implement this into what you're doing at your practice. That's really level 1, introducing you to the system, talking about how to screen people, showing you some corrections and how to do it. And again, if you're looking for a discount, we got a 10% discount. Trying to really use this as an opportunity to get the message out on this really cool event we're doing at Duke. Level 2 actually takes it obviously to a little bit higher level as far as exercise, but looking at progressions, looking at how to use the FMS to build a good program. We take each test and break each test down. Talk a lot about how do you start with basic corrections, building you all the way up to strengthen the patterns. We do a lot with case studies. We make this one a lot more interactive, a lot less lecture at the level 2, more hands-on and lab type stuff. So that's what we do in level 2. And both those courses, again, they're going to be taught at Durham. And then the SFMA is only for medical professionals. So chiropractors, PTs, athletic trainers, we don't open it up to personal trainers or strength coaches, not because, I don't want to make, try to feel like we're weeding anyone out, but based off some information they go through in this SFMA, they teach some joint mobilizations, they do more hands-on type techniques. That's what they do. The corrective exercises, quite honestly, are going to be very similar or the same. But they talk about treatment strategy, talk about treatment, talk about that sort of stuff in this seminar. So really only for medical professionals with that one. But again, they're doing both level 1 and level 2. And this one is pretty close to full. FMS level 1, level 2, there's limited space for that one as well, because we don't want to have, based off of this being at Duke, based off of what we're trying to accomplish, there are some limited spaces. And, the other thing is, if you call, the first 10 people that call in, we'll throw the Applying the Model DVD. We'll throw that in as well. So we got a great thing coming up. We got more than just this one, but I think based off of Gray and I and who we're going to have there and all the stuff we're going to be teaching at this one, this is a pretty special event. So if you can, do what you can to try to make it. You can certainly get the discount does end June 29th. So you got about a week and a half to try to call in and try to take advantage of this. And then if you call in hopefully the next day or so, one of the first 10 people, we'll throw in that DVD for you. So I hope I'll see you at this event. It is pretty special. I hope that we were able to cover at least scratch the surface from some of you guys that aren't familiar with the FMS, but other people who have had the FMS. At least some of this information has been beneficial as far as some of the things we're doing in the future, as far as some of the research is coming out, how to use the information, things like that. So right now, Sean, if you want to open it up for some questions, I'd be more than happy to do that.
Absolutely. Yeah, we've got a ton of questions here. A lot of folks engaged during the call, so we've got tremendous information to keep sharing. And I just want to also add, personally, those of you who know me know I own a company called NPE. We work on the business side with supporting coaches and facility owners in growing their business. And FMS is a great partner of ours. That's why really here supporting and introducing many of our folks that are on the call today to the FMS program. But I'm going to throw another bonus on the table, because I'd like to support everybody in signing up for this event taking place this summer. And everybody who signs up before next Friday, we're going to go ahead and bonus you with our Physician's Referral Toolkit, which is a complete marketing system for helping you increase physician-based referrals for your practice, whether you have a physical therapy practice or you've got a fitness facility. It'll be a tremendous program to support you on marketing and increasing referrals that are coming into the facility. That's a program we sell on our website every day for $800. So I'm going to gift it to everybody who signs up by Friday. And I'll tell you, the first 10 who sign up will not only get the Applying the Model DVD from FMS, but we'll throw in a consultation with one of our business coaches here, which is a $250 value. So we didn't even talk about this before the call, but just listening to the tremendous information that Dr. Burton has shared today, and really incentivize our folks who are here to invest in the program, their education, and want to throw another bonus on the table to help make this a no-brainer decision for you to move forward. So that being said, let's get into some questions. And we've got several here, Dr. Burton. I'm just going to kind of fire them away at you. Some are easy, some are kind of short, some are longer, but we've got around the wheel here. The first one is in regards to practicing the FMS. Do you have any recommendations? The key to understanding the FMS is practice. And do you have any thoughts on how to get as much practice as possible in terms of finding participants? And this is from David Soto.
Yeah, I think if you're just now starting to, whether you got the home study or whatever you've done, even if you just picked up a DVD or read the book or talked to people and you want to do the FMS, yeah, practice. And the best thing is try to maybe contact your local high school to see if they have an athlete trainer. High schools are great. They're working out over the summer, and the movement screen is not going to hurt anybody. I mean, it's pretty basic stuff. I mean, if they're working out, they're doing stuff, that would be my first thing. You got your friends, you got your family. Obviously, those are great guinea pigs. But just go, contact the local high school and see if they'd be willing to let you come in and just do some screening. I mean, that's been our thing. And from the get go, hey, just get some screens under your belt, let you screen some people, and then from that point, most people want to know what to do. I mean, the first time you screen somebody, they're going to say, okay, I've got these limitations. What am I supposed to do about it? And I think that opens the door for the other stuff. So, that's the thing. I think, my thing will be contact your local high school. Most of them have athlete trainers. If not, talk to the coaches. Just tell them hey, you're just, basically you're doing some work on your own. You just want to practice and see if they'd be willing to let you do it. And I can't imagine many people wouldn't allow that.
Okay, terrific. Next question comes from Rich Cimadoro. And Rich's question, it says here, thanks for presenting this. I'm newly certified and enjoying the information and working on applying it. I've been a chiropractor for 12 years, so obviously the structural model of dealing with soft tissue issues makes good sense to me. Can you give a little time to theory out there that criticizes this approach as useless? There's a site online that states comparing the overhead squat is as relevant as assessing someone's tennis serve. Totally irrelevant. I don't want to misunderstand the FMS purpose. I think it's a crazy statement, and I disagree with it, but I'm more curious from your standpoint what your take on that is.
Yeah, I appreciate you asking that question, because that's like I said, when I start now, I mean, there's been so many, now that it's become popular, more people are trying to poke holes in it. And believe me, we are our biggest critics. Myself, Gray, the people we look for advice. Doing these webinars, getting these questions like this are great for me, so I can continue to hone my skills. And for a person that puts that up there doesn't know the system. The squat is just one of the tests, and the overhead squat, like I said, it's the pattern we're looking at. I'm not expecting many people to be able to do an overhead squat the way we have you do it. But biomechanically, I would argue that the squat is a very fundamental movement that many people should be able to do. And if you look at how you're going to squat down to roast a marshmallow by the campfire, it's going to test your ability to use your ankle and foot, use your knee, use your hips, use your core, use your upper body, and just to be able to get in that position. We were meant to squat down. And, over time, we have lost the ability to do that for many reasons. But that doesn't mean we don't need to check it. That doesn't mean we just need to say, okay, well, we're our population, we're not good squatters, so let's just quit. That's like saying, well, because most people are not doing good on this test, let's lower our standards. well, why don't we just keep our standards where they are, try to get people moving better? That's our statement. So for someone to make that statement and say that, the overhead squat is, I'll make an argument. The overhead squat is not a functional movement. Okay, but let me make sure before we get a bunch of other questions with this one. You're not meant to squat with your feet parallel, your feet narrow, and your hands above your head. But we have to test you that way so we can then get the information we're trying to get. Because again, our statement is we're looking to make sure you can squat. Now, if that's with the board under your heels and making sure you can do it okay, that's fine. But by us putting your arms above your head, we're taking it to the extreme. Because my thing is, if you want to be an overhead squatter, let's say, I'm going to train Sean, and Sean's goal is to do some overhead squats. Well, then first I want to make sure he can do it with his body weight. That's my goal. So I think it depends on the person, but that person who's making a statement like that is very naive to our approach and what we're trying to do.
Okay, terrific. Next question we've got here is from Kyle White. Kyle asks, I have many clients that quit their physical therapy because they didn't believe they were making progress. If they aren't open to returning to therapy, how do I address their training sessions?
I think this is the one thing that Gray and I are seeing more and more as we go out and teach this, and Brett, with what he does, Brett Jones, and the groups he teaches. The one thing that we have tried to really do from the get-go is get the medical professionals and the personal trainers and strength coaches communicating. And I think that's really what needs to happen. Now, honestly, I understand where you're coming from. I mean, if you try to pick up the phone and talk to some certain physical therapists or certain chiropractors, they're just going to blow you off. But I think it's up to you to take the higher road and try to reach out to those people and say, listen, I want to train this person. Give me some ideas on how we can work together with this. And quite honestly, if that person is not getting what they need from the therapist and they continue to have problems, or whoever the medical professional is, I don't want to throw anyone under the bus. I think we all have to own this problem a little bit. I think it's they need to get a second opinion. They may need to go seek out another person, and that's one thing we're trying to do on our website is create a little network of like-minded professionals that you could maybe look at referring people to. I mean, we want to refer people who are personal trainers. We want to have them getting referrals from the medical professionals, and we want the personal trainers referring to our medical professionals. So I think the communication is key, and I know that that's probably easier said than done, but at least make the effort and then talk to your client, because ultimately you may have a better shot or you may make more inroads with that client than the therapist does or clinician may by just taking a few extra steps or making a few extra phone calls.
Okay, terrific. We have several questions coming in here. This one's from Billy Beck, a good friend of mine on the call here. His question is, what's the best way to train staff and manage them or manage the FMS within a training center?
So, all right, let me make sure I get the question right. So you're asking how does the best way to train your staff up?
So if someone wants to implement the FMS as a standard screening in their facility for all their staff to execute, what's the best way to introduce that and get them trained up and manage that within a facility?
The best way is going to be doing in-service. And what that in-service entails is having one of our instructors come in because it is every facility is a little different. And what I have found is by going into these facilities and teaching a in-service type situation where you've got everyone there's on the same page, you got access to a small group, you got an instructor there the entire time, you got your full attention. I think that's the best situation because that way you can cater it to what you guys are doing, who you're seeing. You may go in. I've gone into facilities where they're treating mostly just weekend warriors, older individuals. Then I'll go into a facility where where it's a university setting where they're seeing all athletes. Two totally different situations. They're going to use the screen different, and I think that's going to be the best situation. So you can be very consistent in how you approach things. So having an in-service is going to be by far your best bet, and you can actually get into a little bit more information that route as well. What we recommend doing is having the home study course. Everybody take the home study, do the screens for a little while, and then having one of our guys come in and teach really what we turn into a hybrid kind of level 1, level 2 type situation where we can really cater it to what you guys need.
Great. What's the best way for someone to get more information on that?
Contact us to go to Functional Movement. Cress at functionalmovement.com typically sets those up. And what we do is we get some information from you, find out, what type of facility, who all's involved, and really cater the instructor to best fit your needs. Because we've got instructors, we've got everybody from MDs teaching, chiropractors teaching for us, TTs, ATCs, personal trainers. We've got, Mike Contreras is a firefighter, and he teaches workshops. So we really try to get the instructor that's best going to fit your needs.
Excellent. And Billy's down in South Florida, but he's also a Pittsburgh guy. So I know all your guys are running hard on the road, but maybe we'll get Brett Jones down there.
Yeah, exactly. But I'm sure going down South Florida is not a bad place to go. There
you go. All right. We'll keep going. We got several more questions for you here. So this one is really a client question. Says from Sarah. Last name is Gahagan, and Sarah says, I have a client who was discharged from PT due to lower back problems. He retired 2 weeks ago after a job which required him to sit quite a bit. He got a 3 for the ASLR and TSPU. He has incredibly tight hamstrings that don't seem to budge. I've been foam rolling, single, double, leg lowering, and other FMS exercises to stabilize his core. It doesn't seem to be changing. He still cannot toe touch after a couple of months. Anything specific you suggest I do? Maybe your top cues or exercises.
All right. So let me. I don't. All right. So they were 3s on the leg raise.
Not easy to do via the phone for clients.
Right. Yeah. And I'll try to give you some ideas. My first question is going back to the pain. They were discharged, but are they still out of pain? It sounds like to me they may have some muscle spasming or something still underlying. If they've been discharged, if they've been totally released, is the person hurting? I probably need to know a little bit more about them. Or do they have any pain? Are they totally pain-free? Those are things I'd want to find out first. As far as the exercises, it looks like to me they've got a motor control problem. And I would go back to maybe some rolling patterning, some half kneeling activities before I'd go right up into some toe touch activities. I'd look at some half kneeling, look at addressing the asymmetries in half kneeling, maybe look at rolling, maybe look at some asymmetries in rolling, some things like that. Sounds like to me it's more of a motor control problem. If you got the leg raise looking good, I would focus maybe more on some half kneeling before you got them actually standing.
Okay,
great. But go back and dig into the pain a little bit more and see if they may be experiencing pain after they work a few hours, and if they're getting some of that pain, that's going to disrupt some certain things.
All right. Sarah also has a follow-up question there. Could she administer the SFMA simply as a certified personal trainer, or would she have to be a physical therapist? If you said the FMS would show if they need to go to a therapist, when does a certified SFMA instructor come into the picture?
Yeah, I would say with the SFMA, the basic, it's an assessment, and I think what's going to happen is, a lot of there's similar tests in the FMS as the SFMA. The information that you glean out of the SFMA is where you really need to be a medical professional, because where the SFMA is going to take you, it's going to take you down some certain paths that are going to require that we would suggest certain treatment options that may be beyond your scope of practice, and that's really where it comes into play. But we're working on, honestly, and I know where she's coming from, because I think this is a real problem in a lot of different situations. You've got these clients who, they went to therapy, they've gone through the proper steps. You're trying to do the right thing, they're not getting a lot of success, or you're not having as much success as you want, because the therapy or the medical professional they saw did the very basic, rudimentary stuff. And I think one thing is our website. We're really trying to work on our website, being able to connect to different individuals. That's the one thing. So, if you have a professional in your area, I think Sarah asked a question. Sarah, if you got a professional in your area, really, if you got a therapist, a chiropractor, anybody that you respect, maybe try to get a second opinion. Even maybe talk to one of your other trainers in the area and see if they've got, any advice for you. You can look on our website and you may be able to find someone. If you send an email, we can maybe connect you with somebody depending on where you're located.
Okay, terrific. We've got several more questions here. We're going to try to get to as many as we can today, but we do have, Dr. Bird, I think you've got a hard stop at 3:30 today. Is that right?
Yeah, 3:30, and I'm sorry, I got to take off. I do definitely. If your question can answer, certainly shoot us an email.
Okay, so we'll keep going for 10 minutes, 10 more minutes here, and get as many as we can. But just a quick housekeeping announcement. We got a message here from Dr. Burton's office manager while we're on the webinar, and they say the phone is absolutely ringing off the hook at the office for people trying to call and register. So if you're trying to call in, please just leave a message or when you call or call back, and they'll get back to you. You can also send an email to info@functionalmovement.com. Again, that's info@functionalmovement.com. And so we can make sure you're one of the first 10 who registers or register to take advantage of the bonus before we sell out. So again, the phone number to the FMS office there is 434-432-3677. If you just get the answering service, leave a voicemail with your name, number, email address. Those will be time and date stamped for order processing and for bonuses. Okay, back to some of our questions here. So we've got, here's a simple one. This is from Robert Simononik, and Robert's question is it set in stone to order just 3 reps of each screen? For me, I would really like to see more reps. So when should they stop doing reps in a screen assessment?
Yeah, we're 3 reps. We're going to give you 3 reps to get the best score. And yeah, that's set in stone. Now again, that's our screening process. Now, what I would recommend, Robert, do the screen the way we got it set up. Do the 3 tests, and you should be able to. If you look at it, score it low. I mean, the reliability we've got now is pretty much as good as we could, better than we would ever expect it. So, do the test the way we got it set up. However, once you get the low score, once you determine what you feel like is the biggest dysfunction, there's no reason you couldn't look at that test more often. I mean, do the 7 tests, do the way we got it set up, then go back, because that's the one thing why we say this is a tool. You may do all 7 tests, and you may be so focused on the squat or the hurdle step that when you do the leg raise, you realize the leg raise is a total disaster. Well, doing 3 more reps on the squat is not going to make that leg raise better, and that's where you're going to start. So doing all 7 tests, then looking at that, and if you want to go back and look a little bit deeper at certain tests based off the end result, then I would definitely say do that. But don't really get caught up. And the idea behind the movement screen is to be in and out in 10 minutes. And then with those 10 minutes, you may determine you need to be doing more testing, which is fine. But again, don't worry about doing 6 or 7 reps, because then you're going to find yourself overanalyzing the movement. And what we're looking to do is finding the biggest dysfunction. Once you find the biggest dysfunction, you may want to go back and analyze that a little bit deeper.
All right, terrific. And we've got a few questions here on the event, the workshop itself that you're hosting at the end of July. First off, could you pull up the level 2 slide again? Someone wants to get some information on the level 2, and just review what's included in the level 2 course, please.
Yeah, basically level 2, we review a little bit of the screening, but really the intent is to have everybody in the group get screened, as we do in pretty much every one of our course, and then we start working through different cases. We discuss the different cases. We start talking about corrective exercises for each, so we go a lot deeper. We just really scratch the surface in level 1. Level 2, we talk about what we would do for basic stuff for the leg raise, basic stuff for all 7 tests, all the way through lifting heavy. And then we start talking about how to implement this into different progressions, different programming, and we get into more, we talk about case studies. We throw out different ideas, just like the question I think Sarah had, what do we do if we got this situation? How do we approach it? And I think we dive a little bit deeper into the cases. So it really is designed to be a lot more interactive and going through a lot more exercise information.
All right, terrific. And here's another question, just on the event again. And I know this is a special event in that, you guys are traveling and doing courses all across the country and internationally, but this is, as you said, really a summit where it's both you and Gray, both founders of FMS, for 4 full days. And someone can come in, not just take FMS Level 1, but they can take FMS Level 1 right into FMS Level 2 and go through the whole program. Is that correct?
Yeah, that's correct. Yep.
Excellent. So that's an unusual opportunity for you to get 4 days intense learning with the founders, get everything you need to add more value, to take care of your clients, your athletes, and really taking this information home to improve your business. Here's a question on just folks want to just review a comment you had earlier. Normally, this is that your Level 1 and Level 2 workshops are a day-and-a-half events, and this is 2 full days to each level. Is that correct?
Yeah. Typically we do 8 to 4, 8 to 5, and then an 8 to 12 day for our Level 1 and Level 2. And then this one obviously is going to be 9 to 4, 9 to 5 each day. So we're going to add in, based off us having a few different people there, we're going to have we're going to add in a little bit of extra content.
All right, terrific. And then we've also got someone here who has a question. This is from Philippe Tomaszewski, who is actually a client of ours, who asked, what are the advantages of and the differences between being CKFMS certified and the 4-day course taught by you guys? I guess the one here, the summit.
Yep. Yeah, the CKFMS, for just to kind of bring everybody up to speed, is the RKC, which is the Russian Kettlebell Challenge or certification. We've been working with Pavel and those guys, and that's really how Sean and I got connected through Brett for a few years now. And then we basically they started using the FMS, and actually they created a course, which is the CKFMS, which is taking the Level 1 information as well as our Level 2 information, and just applying more to the kettlebell community. So a lot of the information is very, very similar. I'm not going to tell you it's not, because it is. You're going to get your Level 1 cert, you're going to get your Level 2 information, but they cater it more to, like, the corrections. A lot of the exercises are geared more to using a kettlebell, whereas the information we're going to provide in our seminars is not going to be geared towards any one particular thing. We'll talk about kettlebells, we'll talk about bands, we'll talk about, dumbbells. That probably is the biggest difference. The philosophy, the underlying message is going to be the same. There's not going to be any difference in that. And a lot of the, similar presentations, to be quite honest. So it's going to be a lot of the similar information.
Okay, terrific. And someone also asked if you just pull up the slide, just the summary of the details and the bonuses for signing up again as well. So a couple incentives to go ahead and reason to lock this in now. Not only is this a unique opportunity to learn from Dr. Burton and Greg Cook, the founders of FMS, for 4 days at the summit, but I know you've got several other your top instructors there. For the 4 full days, you've got added time for case studies, live application of the FMS system, and really mastering the system, not just going to a workshop for a day or two and kind of hoping you can go home and figure it out, but live application with the founders, learning this quickly, and then immediately applying when you get back to your facility and to your client base the next day. And you have a 10% discount offer for signing up by next Friday, June 29th. You can register just by calling the FMS offices at 434-432-3677, or if you're going to get a voicemail because the phone's ringing off the hook over there. It's a little bit like a radio show calling in right now. But you can also send an email. You can shoot an email to info@functionalmovement.com. Again, that's info@functionalmovement.com. Those will be time and date stamped, and we'll make sure, if you're one of the lucky ones, to make sure to get you the bonuses. And the first 10 people who register, you're going to get the Applying the Model DVD set. It's a 4-DVD set. That's some tremendous information, again, for you to take home, more application of the FMS model, and I believe that'll be shipped out quickly, so you can actually probably review that in preparation for coming to the event, and even get you queued up before you get there at the end of July, which is tremendous. And then we went ahead, NPE is adding a couple bonuses today as well. For if you purchase by next Friday, we'll be including our Physicians Referral Toolkit, which is a marketing referral system for you to increase the amount of referrals coming into your practice or your fitness facility. It normally sells on our website for $800. We're going to bonus that up for everybody who signs up by next Friday. Then for the first 10 who register, you're also going to get a consultation with one of our business coaches here to answer questions on implementation in your practice on the business side, support you where we can, and really effectively communicating the FMS to build it into added value in your packages and your service offerings of your menu, whatever your practice may be, in a fitness environment or in a more of a clinical as well. Just one more question, a simple one to close things out. And I'm sorry, we've got, I would say literally 50 questions that have come in here. We don't have time for them all today. Dr. Burton's got to run. But this is a simple one we can bang out. Someone says they've been doing the FMS screen for several months now, since January, and should they keep their shoes on or shoes off?
Oh, that's easy. Yeah, keep your. We always tell people whatever they're going to train in, to wear that footwear. So whatever, we say keep the shoes on. Whatever footwear they're going to train in, do that. The biggest thing is be consistent. So if you screen them, if you've been screening them for a few months now with their shoes off, just keep doing that. We just recommend keep their shoes on. It's a little bit easier. The footwear certainly does make a difference, but there are people out there who may have some orthotics or may have certain things. Keep them in that. Keep them with whatever they're training in, but be consistent. If they wear Nike Freeze in or Vibrams in today, and you screen them today, have them wear the same shoes next time you screen them. That's probably the biggest thing to consider.
Excellent. Well, thank you all for attending the webinar today. Again, you can register now by calling the FMS offices at 434-432-3677, and the discount will end next Friday, so you have time to book in. For those of you who also asked, we will post a replay within the next 24 to 48 hours, so you can go back, review it. If you showed up late or had to leave early, you can review the information covered today in the Q&A with Dr. Burton. And also encourage you to act fast, so you can take advantage of the special bonuses that are included. This was received so well. We had well over 1,000 people registered today, and a ton of questions. I know that we'll be doing more of these in the future, more Q&A opportunity with Dr. Burton and the FMS team. So thank you all for your time today, and we'll talk to you soon. Bye-bye.